This is a typical dose response curve. We give an increasing concentration of a drug, and we see the drug response go up as the dose increases. And what we have here is the control group where we give the drug. They didn't get any albuterol until it was time to expose them to the beta agonist. They actually exposed them to isoproterenol, which was a very old beta agonist we used to use a long time ago. At a concentration of, let me find my numbers here, of 1 micromolar, they saw after they had been exposing them to larger concentrations that they were seeing a smaller response. And this was a smaller response, not just by dose, but also by duration of incubation. So the longer they incubated or exposed this airway tissue to the longer they exposed the airway tissue to the beta agonist, the less likely it was to respond when they challenged it to try to get it to actually bronchodilate. Fortunately, when they exposed the airway to dexamethasone, they saw that that actually went away, and we returned back to normal. And I took out another slide that I had, but this has been demonstrated even with single doses of inhalation in humans as well, where if you give a beta agonist chronically, you sometimes need more to achieve the effect, but we don't do that. We give beta agonists only on an as-needed basis unless they're used in combination with an inhaled steroid, which mitigates the response of the airway to become tolerant to the beta agonist. So the next myth is nebulizers are the preferred route of therapy for asthma medicines. And I've got several different studies. I'm going to go through them relatively quickly. But in essence, this was an emergency room visit, study. The children were relatively small. I think on average they were about a year old. They were only children less than 5 years old. They gave a double-blind, double-dummy study, which essentially meant that everybody got a meter dose inhaler and a steroid, and a spacer, and everybody got a nebulizer treatment. People that got one got a placebo, the other one was active, and then they swapped them out and evaluated again. And what we can see here is that the clinical score was similar in both groups, pre-treatment. Post-treatment, the response was very similar between the two groups. Interestingly, the heart rate was significantly higher in the people that received the albuterol through the nebulization therapy compared to the others. So clinically, they were equivalent. Toxicity-wise, we had an increase in side effects, potential side effects with an increase in the heart rate. This is another study that was done in the emergency, this was in admission. This group, the people in the meter dose inhaler group, were actually a little bit sicker. They had a higher score, but after they controlled for that admission score of severity, they found that the admission rate was actually lower in the spacer group. They found that the number of treatments required was somewhat smaller. Thus, clinically, it's probably not as significant. And the number that actually had to get steroids in the emergency room was actually lower in the meter dose inhaler group. So anybody that says that you got to have a nebulizer to get good effect in a little kid is wrong. And there's plenty of literature to counteract that myth. Asthma can be cured. If we had a cure, somebody would be extremely rich, and we wouldn't have everybody coming into our clinic and our emergency rooms. But almost any time you get on the internet, you get these emails, you see late night television, there are all kinds of asthma cures. Excuse me. One that might be interesting to look at, although if it were a cure, it would be widely recognized and received, is something called buteyko breathing. This is something that is going to be explored a little bit more in the future. But there's been several clinical trials, and essentially this was done by a guy named Buteyko in the Ukraine back in the 1950s. And the idea was that if you breathe fast, you blow off your carbon dioxide, you get something called hypocapnia, which is essentially just lower carbon dioxide in your bloodstream, and that somehow causes asthma and other diseases. What was interesting, though, is that they treat the patient by having them do these controlled breathing techniques where they reduce the respiratory rate and the depth of breathing, or their tidal volume. And there's been a couple of studies that have been done. This study looked at buteyko breathing versus placebo and actually showed pre to post that it was a better improvement in the reduction of the bronchodilator use. People had to use less bronchodilators. The mean difference was negative 220 for the people in the Buteyko group versus negative 10 in the placebo group. Not a miracle cure or anything, but it's interesting, probably needs to be studied. This study actually looked at pranayama. It's a device that sort of simulates an Indian type of breathing called pranayama, and they actually saw that in people that got the Buteyko breathing, more of them were able to have steroid reduction. Their inhaled steroid dose could be reduced over time. Now, this is not anything that's conclusive at this point. More study needs to be done, but it's interesting because the Cochrane Collaborative in June just published the protocol for a review that's going to be done to see what the level of evidence is across all the studies that have been published so far. So you might want to keep your eyes on that, whether or not that actually is going to pan into anything. I'm not really sure. But certainly we know asthma can't be cured, but there's at least some interesting things purported as a cure that might actually be beneficial. Asthma symptoms means no asthma symptoms mean no asthma. This was done by Dr. Teeter, who used to work at the University of Maryland with Gene Bleecker. And what they did was they looked at the percent predicted of FEV1 in the clinic patients versus their clinic symptom score, which was essentially a bunch of symptoms of asthma with a frequency rating, and they totaled the numbers. And the whole point of this slide is to show you that between these patients who are inner city adults, and these were inner city adults on the clinic side, those were hospitalized patients. What's interesting and relevant is the fact that people don't always perceive their symptoms very well. I mean, essentially we have a scattergram on the right-hand side. My child will outgrow asthma. Another asthma myth, there is some evidence that there may be a situation where about 30 to 80% will have their asthma come back after they get to be adulthood, after they get into adulthood. Asthma diagnosis in young children is problematic, and there are some people, though, that seem to have remission. And this study was actually a cohort study that followed patients over a longitudinal period of time of about 30 years. They started when the kids were between 5 and 14. They followed them in their 20s and again in their 30s. And what's important here is to note that complete remission of asthma was found in only 22% of the patients. How those patients are different, I'm willing to bet Dr. Weir is going to figure that out when she's looking at her phenotyping. There's something different about these patients, but it's only 22%. Then there's also patients that appeared to have clinical remission symptomatically, but when we look at it, they also have bronchial hyperresponsiveness, and their FEV1 is not what it should be, even though they weren't taking medications. People that have physical activity, people with asthma should avoid physical activity. All I can say is talk to the bus. Okay, this is a breathmobile. Jerome Bettis is my hero. He's an honorary member of the Asthma and Allergy Foundation board, and he got a Super Bowl ring, and he has asthma, and he is a fantastic role model, even in Baltimore City Ravens fans that are this big. Okay, Jackie Joyner-Kersee, gold medalist. Asthma will hold my child back, or asthma will hold me back. With proper trigger avoidance, the right medicines used the right way, and with people promptly recognizing their symptoms and being treated for them appropriately, the myth of the pot of gold at the end of the rainbow, for this myth, is probably debunked also, because people can control their asthma. And that is all that I have. And at this point, I guess Dr. Weir will address questions from the audience.
Yes. Question. If you take medication over a long period of time, let's say you inhale a corticosteroid, does your body become what's the word, tolerant to it? Like every other medication you take for a long period of time, you have to switch up the medication?
Have not seen any scientific evidence of that, and I updated all my literature searches to find the current evidence, and I couldn't find anything about that. Beta agonists, another story, which is why we want to use them with the inhaled steroids, which turn that effect completely on its head.
Can you talk a little bit about the impact of the developing lung when using these types of medications on children whose lungs are not yet developed?
So, the prenatal or peripartum use of inhaled steroids. So, asthma in pregnant women is actually a whole different topic. And asthmatics who get pregnant,
I meant the child.
right, you're talking about the developing fetus.
No, I meant the child.
Oh,
The
okay.
child, as the child grows, the lungs are, the body's growing.
Right.
So does it stiffen the lung? What impact does it have on the child's lungs as the child grows after it's born?
So what we do know is that some people go on to have permanent damage to their lungs, and they develop what's called fixed airway obstruction. But that's typically described in adults, never in children. Children, I mean, I think she addressed it best. Some of them do outgrow it, but a lot of them don't. Or if they improve, they recur as an adult.
She's asking if the medications have a long-term effect on children.
Oh, that's a totally separate question. Okay.
Is that what you were asking?
I want to know, as the child develops and their lungs are growing, does it stiffen their lungs? Do they have the same lung capacity as if they hadn't been on those meds as while they were growing
Well, it's not the
up? I mean, what is
medications. The
impact on-
medications improve their lung capacity. If they don't use the medication, they can be left with fixed airway obstruction. But I think what she was mentioning was what effect do these drugs have on children in general? And you know, it has to do with, I'll only talk about the inhaled steroids because that's really the hot topic. All the rest of the leukotriene receptor antagonists are very safe. We really just don't know any side effects in children. The inhaled steroids are either low, moderate, or high potency. And the high potency, you know, the drug manufacturers want you to think that they don't impact their growth or suppress their HPA axis. I think with the high potency they can, which is why you want to continually reassess, adjust their environment, add all the adjunctive, and do anything you can to avoid the use of high potency long term. Does it stiffen their lungs? No. If anything, if you don't use the correct medication, they'll be left with long term sequelae. Does that answer your question?
That's fine, thank you.
So I was interested in your study about the TZDs being used. Do you foresee the systemic side effects of oral medications being a barrier to physician prescribing if the study is successful?
Which side effects?
For example, the exacerbating heart failure.
Right, right. So that's an excellent question. So there's pioglitazone and there's rosiglitazone. Rosiglitazone is really not used much anymore, if at all. I think there may be a few patients who were on it and cannot be taken off it who are still getting it. That's the primary reason why we chose not to use that TZD, thiazolidinedione, in our study. Pioglitazone is not as strongly associated with heart failure. And I'll say that it doesn't give you heart failure. If you have a tendency toward heart failure, it can exacerbate it. There are multiple side effects with any drug you use. And one of the big things that we have to deal with is this drug safer than chronic oral corticosteroids? And I'll tell you, I think pioglitazone is. So long term, we'll have to see. Right now, we're still stuck with, is this efficacious? Is this something I can offer my patient? Does it work? And if it does, then which phenotype, how long, and all that. But you know, oral corticosteroids are so incredibly toxic that we really should be working aggressively to find some way to take these patients off of these drugs.
Thank you.
Thank you.
Yeah.